Thank you for joining us, our guest and our esteemed colleagues. And today we'll be sharing our case with diagnostic dilemmas. So we'll start ahead. We'll introduce our patient. This is a 55-year-old Middle Eastern female. She was referred to our clinic for a second opinion. Mainly, she had been complaining of recurrent episodes of paroxysmal severe hypertension. These surges of high blood pressure were also associated with palpitations, headaches, chest tightness, flushing. And the patient had noted that they were precipitated mainly by any salty food or salt intake, as well as cheese and chocolate. These episodes have been going on for a while, almost a year, and they are persistent and recurrent. The patient is completely asymptomatic and normotensive between episodes, and she had done a previous charting that proves this. Otherwise, her history is unremarkable. Upon physical examination, she was vitally stable. There was no evidence of any orthostatic hypotension. And to conduct a physical exam looking for any signs of any endocrinological disturbance, there weren't any. Essentially, it was a normal general examination. We had reviewed her previous reports. She had conducted previous evaluation, and it had ruled out hyperaldosteronism previously, as well as a normal baseline endocrinological evaluation, including metanephrines and catecholamine. Additional cardiological workup included a normal angiography, echocardiography, as well as a Holter monitor. However, we can't stop at an interesting imaging finding. An abdominal CT scan that was performed earlier had showed a large mass, around 4 to 5 centimeters, noted in the right side of the abdomen, close or above to the adrenal gland. So we kept this finding in mind. And this is a cross-section of the imaging that we are pertaining to. As you can see, we've noted here the mass. On the right side, it is well circumscribed, nodular, and around 4 to 5 centimeters in size. Additionally, a previously done imaging had noted a unique feature of this patient, as the liver was detected to be on the left side, the spleen was seen on the right side, and there was even a right adrenal subcentimetric adenoma. However, the heart of the patient was seen in its normal anatomical site on the left, and therefore the patient was diagnosed with heterotaxy syndrome as an abdominal situs inversus. And if we go back to our image over here, we do realize that the liver is in fact placed on the left side. With this highlight clinically and biochemically, we proceeded to build our diagnostic framework. We initially thought of possible endocrinological differentials, including pheochromocytomas, paragangliomas, carcinoid syndromes, and other functional neuroendocrine tumors. The non-endocrine entity to be entertained as well, we thought of possibly pseudopheochromocytoma, and we even expanded our differentials to include any underlying autonomic dysfunction or any salt-sensitive hypertension condition. Before diving into further workup, it's important to refresh some of the biochemical profile of those tests we're conducting. So when approaching pheochromocytomas or paragangliomas, typically we are guided by our clinical suspicion. We move on with biochemical confirmation, and eventually we localize with imaging studies. But we keep in mind that although plasma metanephrines as an initial screening tool perform very well in sensitivity, around 99%, however, we still have a considerable percentage of false negatives, reaching up to 15%, possibly to small tumors, intermittent secretion, or low secretory potential. This is why it's important to keep in mind, as guided by the guidelines, that a normal or a negative result does not particularly or definitively exclude the diagnosis, especially when we have a high suspicion of in the case. Looking at carcinoid syndrome, usually we are guided with a 24-hour urinary 5-hydroxyindoleoacetic acid as an initial diagnostic test. With the following performance for sensitivity and specificity, however, we keep in mind that the levels do fluctuate with symptomology, and there is also a potential for false positive results as there is interference with foods and medications. And talking about chromogranin, it is a biomarker for neuroendocrine tumors in general. The levels do tend to correlate with the tumor bulk, regardless of whether the tumor is functional or not. With the following specificity and the sensitivity, however, we can also see elevated levels in other conditions, interfered with medications like proton pump inhibitors or conditions like renal insufficiency. Our plan after the first evaluation was to obtain a 24-hour ambulatory blood pressure monitoring, rule out pheochromocytoma and paraganglioma essentially, and rule out carcinoid and neuroendocrine tumors. Now, despite having previously negative results, however, the patient's symptomology was significant. The episodes were persistent, her complaints were, they were still interfering with her daily life, and it was imperative that we confirm truly the negative workup. We obtained a 24-hour ambulatory blood pressure charting of this patient, and essentially it was a normal blood pressure reading. There were no episodes of hypertensive nor hypotensive readings, and this is on an episode-free day. And then we proceeded to obtain plasma metanephrines and catecholamines as a baseline, both of which came back to be clinically insignificant as the results were barely on the upper limit of normal. We've instructed our patient to collect an additional sample, however, this time a 24-hour urine collection, but to be collected on a day where she does suffer with the episode to see whether there will be an elevation or not. The catecholamines and the metanephrines came back again to be within the normal and clinically insignificant. Further investigations regarding carcinoid and other neuroendocrine tumors with chromogranin, urinary 5-HIAA, and serum tryptophan on days with an episode also came back to be normal or even low. And her other baseline biochemical workup was unremarkable. The patient had even underwent an upper and a lower GI endoscopy previously in another institute as part of her workup. Endoscopy sometimes is considered whenever the primary tumor is unable to be detected or located when imaging fails to do so. And still in her case, both procedures came back to be unyielding. So now we come to our diagnostic challenge. We are faced with a clinical condition where the phenotype is so classically presenting with pheochromocytoma paraganglioma and persistent symptoms, still occurring episodes. However, our biochemical workup, plasma, urine, is all unyielding. However, we cannot say the same regarding the imaging findings, as we kept in mind that we had one finding of a mass around 4 to 5 centimeters on the right side with close proximity to the adrenal gland. So this was not very reassuring. We kept it in mind. And now I'd like to have some little brainstorming with the audience. We can maybe initiate a poll to see what would be the input of our colleagues today. At this point with this case, what would be your next step in the plan? Would we consider functional imaging? Would we reassure the patient regarding her symptoms and episodes? Would we pursue non-endocrine conditions? Would we conduct an MDT with a urologist and a radiologist to review the images in concern, or treat symptomatically and repeat workup after a while? If we can share the poll, if you please. There is no right or wrong answer. We just like to have an out loud brainstorming. If the results are ready, perhaps we can share them. Interesting. So looks like more than 1/3 of the audience believe to consider functional imaging. No one would like to reassure the patient. That's reassuring. There is a quarter of the audience would consider non-endocrine options, perhaps an MDT to review the images, and maybe a small portion would consider to treat symptomatically. Lovely. So in our case, we were not reassured by the imaging findings, and we did conduct an MDT with the radiologist. The radiologist informed us that this mass is in fact close to the adrenal, and it is suspicious and perhaps would require further evaluation. Following this flow chart, we look at patients who are presenting with signs and symptoms suggestive of PPGL or those who have detected suggestive masses on their imaging. After clinical and biochemical evaluation, our patient would fall into this category, where the evaluation was normal, unyielding. But in this case, we do have a positive CT or MRI, and therefore the recommendation or the suggestion goes into the direction of performing functional imaging, and then perhaps referring to a specialized center or a tumor board. We'd also like to highlight the concept of silent PPGLs. So in this case, because of the widespread use of all of the imaging nowadays, we are able to detect the tumors. However, when we come to conduct the biochemical workup, it tends to come back negative. And this is where this term emerged, where they are biochemically silent pheochromocytomas or paragangliomas. But to further expand on the terminology and to categorize those tumors well, when there are no signs and symptoms of catecholamine excess, then we will term the tumor as clinically silent. Should we perform plasma and urinary catecholamines, metanephrines, and methoxytyramine workup and still the results are unyielding, then this is a biochemically negative tumor. Both of those entities together is very highly suggestive that this is a non-functional tumor. However, it's important to emphasize that we can never truly state that the tumor is non-functional unless we do have a histopathological evidence of absence of catecholamine stain in the tumor tissue. This is clinically imperative and of paramount importance, as a negative biochemical test will not exclude the functionality of the tumor. After reviewing the literature, a lot of studies even noted that this is especially particularly important when we are approaching smaller tumors, smaller than 2 centimeters in size, and maybe non-secretory neuroendocrine tumors. Those silent PPGLs with a negative biochemical workup can still be, in certain clinical conditions, provoked in order to cause a pheochromocytoma episode, and therefore will pose clinical risk of significant risk of clinical complications if they were missed. Not only that, but also they will still demand a preoperative blockade of adrenoreceptors before any clinical operation. Now, with our patient, coming back to our patient, it wasn't particularly clinically silent. The episodes were still occurring. They were still clinically significant. So we had to take a further step in evaluation. And we did, in fact, proceed with a functional study using a gallium-68 dot-A scan. Looking at all of the possible somatostatin receptor functional imaging available, including the gallium and the copper dot-A scans, they truly played an important role in improving the detection of tumors when conventional imaging was not able to do so. In certain studies, the gallium dot-A scan outperformed even pentatriotide SPECT scans, and they were definitely more sensitive than the FDG PET and even more specific than the conventional workup. So we did perform this study, and that's the result of our patient. So we look over here, this is the scale of the intensity of the uptake, and we remember that the liver of the patient is on the left side. We see a homogeneous uptake of the somatostatin receptor expression, and we come to see that there is a significantly high intense uptake in this area, which is on the right side, a circular nodular mass of 4 to 5 centimeters. When comparing it to the previously conducted abdominal CT image, we do see that the masses are quite corresponding, and this is the mass that was in question. As reported in the patient's imaging report, there was an intense somatostatin receptor overexpression, which was suggestive of a neuroendocrine tumor. This alarming result required us to perform an MBT. In this case, we met in a multidisciplinary team with our colleagues from radiology, oncology, and urology in order to discuss the results. While we acknowledge that there is a highly intense mass close to the adrenal gland, however, we keep in mind the unique anatomy of the patient, as she's a known case of situs inversus abdominis. And therefore, the question was raised as whether this intense uptake could be reflected by a right-sided spleen. And if so, then how will we be able to differentiate it? For that, we go back to the literature, and we are informed that, in fact, the splenic tissue and spleens do physiologically exhibit somatostatin receptor. They do exhibit the receptors, and therefore they will reflect a high physiologic uptake when performing a gallium dot-A scan. In addition to that, accessory spleens, splenoniculi, and splenosis within pancreatic tissues will even demonstrate a more intense dot-A uptake, and therefore they can pose as a potential site for false positive results. So how shall we differentiate? Is when we came across the technetium sulfur colloid scan. It's a radiopharmaceutical isotope used that's taken up by reticuloendothelial system, that is the spleen, the liver, and the bone marrow. However, they're not taken up by the neuroendocrine tumors or neuroendocrine tissue. And therefore, it can be used to distinguish between splenic tissue and non-splenic tissue without requirement of biopsy. So we did, in fact, proceed with this imaging technique, again, further imaging studies, and this is the result of our patient, where we can see two areas of uptake. This is on the left side, a homogeneous mild uptake representing the liver, and on the right side, again, the mass 4 to 5 centimeters with a more more intense uptake on the right side. When comparing it, again, going back to our abdominal CT scan, we see that it is corresponding to the mass. And therefore, as reported, we will see the homogeneous liver uptake on the livers on the left side, and the nodular soft tissue on the right side, representing the ectopic spleen and the right upper abdomen. And this was, in fact, the ectopic spleen of the patient on the right side, given her unique anatomy. So the patient's journey so far had taught us some important clinical pearls. We keep in mind that normal metanephrines or negative biochemical tests do not definitively exclude the presence of pheochromocytoma or paraganglioma. Additionally, functional imaging modalities, despite being very helpful and very powerful in diagnosis, yet are still susceptible to false positive findings. Anatomical variants should always be kept at the back of our minds during interpretation of imaging findings and listing differential diagnoses. And that accessory and ectopic spleens do demonstrate significantly higher intensity on gallium-68 dot scan in comparison to a normal spleen in a normal anatomical site. So at this point with the patient, we had to consider non-endocrine options. We thought could perhaps be a pseudopheochromocytoma. This describes an entity where the patient would be struggling with symptoms and episodes that are clinically indistinguishable from a typical pheochromocytoma. However, it is a diagnosis of exclusion. We will only be able to state a pseudopheochromocytoma after a completely negative workup of pheochromocytoma and absence of panic episodes or intense emotional states. It seems to be reflecting an altered reaction of the autonomic nervous system with an exaggerated response to an ample production of catecholamines. Another entity to be considered or entertained is salt-sensitive hypertension. It's been described as a physiological trait in which the blood pressure of certain members of the population or individuals will exhibit changes parallel to the salt intake, in which any load of salt or a higher salt intake is going to reflect in surges of blood pressure. And in contrast, any deprivation of salt is going to cause lower blood pressure readings. The literature and the studies have noted that this tends to be more common in individuals of Black race, elderly, and patients already diagnosed with hypertension. So at the end of our patient's journey, we have a 55-year-old lady. She is known case of heterotaxy syndrome, presenting with those paroxysmal spells of significant hypertension, headaches, palpitations, and flushing, otherwise essentially asymptomatic. Her workup was completely biochemically negative. Cardiological workup was reassuring, and the localization imaging studies, including functional studies, were clinically unrevealing. At the time being, up until this day, she is still struggling with those episodes, and she's trying to conservatively manage them with complete avoidance of salt intake. As we brainstorm through this case, we are urged to seek an expert opinion with the following questions in mind as they propose themselves. Could anything could have been done differently throughout the evaluation of this case, or anything additional that could have been done? Are we still working in an endocrine-oriented framework, or are we moving towards non-endocrine differentials? Is there new evidence arising that could guide us elsewhere? And have there been any similar cases encountered, and how were they managed? As we come to wrap up this presentation in this case, I would like to take us to the first slide with a picture of this beautiful orchid. Only to notice as we admire its beautiful colors and its beautiful structure, that it is in fact not an orchid, but rather an insect. This is actually the orchid mantis. It blends very beautifully with the colors and the shape of the flower, basically tricking and trapping the insects for its food. I thought it would be an interesting example from nature of mimicry, and as to how certain objects or phenomena may present as one thing, but eventually turn out to be something very different. Thank you very much.
Thank you, Dr. Raha, for sharing your case and the challenges you faced during the management of this case. And without further delay, I would like to introduce Professor William Young for his commentary about the case and to share his input. We are honored to have him today, and his name actually doesn't need any introduction. He's a professor of medicine in Tyson Family Enterprise Professor at Mayo Clinic, USA, and definitely we all know that he has an international authority on adrenal and pituitary disorders, including primary aldosteronism and pheochromocytoma. So, Professor William, you have gone through the case with us, and definitely you must be having your thoughts to share with us. So please, you can start your commentary, and if you would like to share some slides with us, we would appreciate that. Thank you so much. You can start now.
Well, it's a pleasure and honor to be with you all today, and I really enjoyed that case presentation. Very well organized, nicely evaluated. I do have some pearls to share based on this case. The first is, remember, this patient presented with labile hypertension, palpitations, headache, chest tightness, shivering, and flushing. I have a rule, and that is patients who have flushing spells very rarely will have pheochromocytoma. Pheochromocytoma spells are vasoconstrictive spells. These patients usually get pale. They don't get red. When a patient gets red, that's a vasodilatory episode. It makes me think of a differential diagnosis that does not include pheochromocytoma. Now, you can never say never in medicine. Have I ever seen a patient with pheo who flushed? Yes, I have, but it would be a rare event. So my suspicion on day one would have been fairly low for pheochromocytoma or paraganglioma. I still would have evaluated the patient for those possibilities. The other interesting part of the initial presentation was triggers for these spells were intake of cheese, salt, and chocolate. Usually, information about a trigger leads you to the correct diagnosis, and I'll come back to that in a bit. This patient had an 8 millimeter right adrenal nodule. Whenever I hear about an adrenal nodule, I want to know what the unenhanced CT attenuation is, and that tells me whether this is a nodule that needs to be looked at over time. If it's lipid poor, then it will need further evaluation down the road. I will say that, let's say it was lipid poor, and let's say it was unenhanced CT attenuation was 30 Hounsfield units. Could that be a baby pheochromocytoma? Absolutely, it could. Could it cause symptoms? No. Pheos require a big factory. Unlike an aldosterone-producing adenoma that can be 4 millimeters and cause the whole syndrome, for a pheo to cause symptoms, the factory has to be big. And typically, a minimum size is 1.5 centimeters, and most are greater than 2 centimeters in order to make enough catechols to cause symptoms. The other issue I noted was the plasma norepinephrine was 163 with an upper limb normal of 120. The other rule I have is if a pheo is causing spells, then the lab value should be off the charts. What do I mean by that? More than 5-fold above the upper limit of normal. If a pheo is responsible for classic pheochromocytoma spells, the labs are always markedly abnormal with the spell and in between spells. Pheos are constantly leaking, at least if they're big enough to cause spells. So when I see a plasma normet of 163 with an upper normal 120 and a patient with dramatic symptoms, I know the patient doesn't have a pheo causing those symptoms. Could they have a baby pheo that's incidental, unrelated to their symptoms? Sure. And that small adrenal nodule would be a possible candidate if it's lipid poor. I mean, this case provided the clinicians with some special challenges with the abdominal situs inversus and this atypical looking, what turned out to be a spleen, but it looks like a round oval mass. It looks like it sure could be a either paraganglioma or adrenal pheochromocytoma. So it was really smart to do that technetium scan to show that it actually was splenic tissue instead of a paraganglioma. I'm going to bring up just a couple slides here. Let's see. So I joined the Mayo Clinic staff in 1984, and my main interest then and now was endocrine hypertension. And what became very clear to me was that many clinicians didn't understand a lot of the hurdles when it came to pheochromocytoma, because we would get a lot of referrals for pheochromocytoma, but I would know in the first 5 minutes the patient didn't have a pheochromocytoma, but then I'm left with that patient and trying to figure them out. So I was spending a lot of time on non-pheochromocytoma patients. So I had this bright idea with Dan Maddox, who was an allergist at Mayo Clinic, to write a paper to guide clinicians on how to work up patients with spells and exclude pheochromocytoma. And so this is just the title page, and you can see the abstract here. And as you might guess, that concept was rather naive on my part. Instead of decreasing the number of spell referrals, non-pheochromocytoma spell referrals to Mayo Clinic, this actually increased them. and we were overwhelmed with patients with undifferentiated spells for about a decade. So since I wrote this paper in 1995, I've not written about spells again, and I never will. But what we included with this paper was the differential diagnosis for a patient with spells. And you can see it's really broad. It includes endocrine causes, shown on the top left here, cardiovascular causes, psychologic causes, pharmacologic, neurologic, and a miscellaneous category. And it may be in this miscellaneous category that the answer for this patient is hiding. So as we heard, this patient has flushing spells. Whenever I hear flushing spells, I always exclude mast cell disease. Mast cell disease can be due to mastocytosis with increased number of mast cells, or it can be a mast cell activation disorder where mast cells are activated by a trigger. The patient has a normal number of mast cells, but they're triggered to release their mediators. So a good screening test for mast cell disease is measuring blood tryptase. You can measure it at baseline, you can measure it with a spell. You can also do 24-hour urine for prostaglandins because they're also contained within mast cells. So that's one thing I would do, and the fact that the spells are triggered by cheese, salt, and chocolate may be a clue about mast cell disease in this patient. If this patient does not have mast cell disease, then I would probably treat this patient as a pseudopheochromocytoma, which was mentioned in the presentation. Usually these patients respond very well to adrenergic blockade, typically starting with low-dose beta blocker, and if needed, adding a low-dose alpha blocker. But patients with spells can be challenging, and sometimes the symptoms evolve over time and bring up other options in the differential diagnosis. But that's where I would start with the next steps. Let me just look at the questions that were asked here. Any similar cases in your practice? Unfortunately, yes, I see lots of spell patients still. And I tell them on day one, this is a challenge. It's one of the most difficult things we do is try to figure out what's causing episodic symptoms in patients. And I ask the patients to be patient with me as we work through that long list of possibilities. And in the end, I caution them that we may not have an answer, but we will give them some pharmacologic treatment trials. If with the flushing, they also have marked sweating, so we call these wet flushing spells. Usually we do central alpha-2 agonists like clonidine or guanfacine, and they work really well. Whereas if it's dry flushing, in addition to alpha and beta blockade, we will consider treatment with H1 and H2 antagonists. So those are my comments about this case.
Thank you so much, Dr. Young. And we feel secure that we are not alone in the management. So it seems that it's quite common because we refer the patient to immunologist as well to rule out any food allergies. And we did workup for mast cell activation as well. It came negative, and she's already on PRN bisoprolol for her symptoms. And she described flushing, rather not the change in skin color, but the feeling of warmth. So it's good to know that it's something there, and we can just console the patient for now. And I think we are not discharging, we are keeping an eye in case. And regarding that small adenoma, it's very, very tiny, and the radiologist did not comment on Hounsfield. Actually, they said it doesn't look like that it has increased Hounsfield unit. But definitely we will keep it under the surveillance. So I would like to go for our second clinical case presentation. And our second speaker is Dr. Will Morgan Manara. He's working as a specialist endocrinologist in Dubai Hospital, clinical assistant professor at Mohammed bin Rashid University of Medicine and Health Sciences. And Dr. Morgan is also the recipient of a prestige Dr. MMS Ahuja Book Prize Award during his endocrine training. So Dr. Morgan, you can please share your screen and start your case presentation for now.
Thank you, Dr. Fauzia. Can you see my screen here?
Yeah, we can see your screen and you're loud and clear.
Yeah. Good evening, everyone. Thanks for the nice introduction. So today I'll be discussing the case title, PCOS or something more, the DHES puzzle. So in our clinical practice, we tend to see commonly a clinical scenario where a female young lady walks into the clinic with symptoms of hyperandrogenism. More often or not, after workup, we label such cases confidently as PCOS and move on. And most of the times we are right. But sometimes we have a scenario where we do the workup for that patient, but things don't add up, and that will lead to diagnostic challenge. Today, I'm going to walk you through one such case that looked like a typical PCOS at presentation, but on workup, it looked like a challenging case, which made it us to present here. Androgen excess disorders occurs almost in 10% of women in reproductive age group. Of that, PCOS is the most common, we know that, and it has a very heterogeneous spectrum. And atypical presentations can blur the line between a functional and pathological androgen excess. So the current case illustrates the limitation of conventional diagnostic framework and need for critical clinical reasoning in the evaluation of complex hyperandrogenic cases. So we have a 21-year-old girl, single, university student, presented with chief complaints of menstrual irregularities since menarche, and she had abnormal hair growth since menarche. She attained menarche at the age of 14 years and puberty at the age of 10 years and never had a spontaneous menstruation except first bleeding. This was one of the key thing that bothered the patient. Other history, she also had history of hirsutism since the age of 15 years, no history of acne or rapid weight changes, and she had a normal antenatal, natal and postnatal history, and no other chronic medical issues. She didn't have any family history of similar complaints, and she was labeled as PCOS in the past, and treatment she received were OCPs, myoinositol, vitamins, and progesterone for withdrawal bleed, and she also had multiple laser sessions done for her hirsutism. On examination, blood pressure were normal. Her BMI was 17.75, suggests she had a very thin phenotype, and there were no markers of insulin resistance, and she didn't have any goiter or no features of acromegaly or Cushing's. We could not do the modified FGS score because of post-laser therapy status. And she did not have any frontal hairline recession, but her TANAS breast stage was 4, and she did have a mild clitoromegaly with an index of 40. And she had a normal pubic hair distribution. Her basic investigations essentially were within normal limits, including beta-HCG, thyroid function test, prolactin, and baseline investigations. So these were within normal limit. Now let's go into the hormonal workup. So we have hormonal workup, which was done in 3 different days. One was a random sample. The other 2 were after the withdrawal bleed. So it's an early follicular phase. You can see the ratio of LH and FSH. The LH is significantly more than FSH, and the ratio is more than 2 to 3:1 in all the 3 occasions, suggesting of a PCOS pattern. Coming to the testosterone, it was again elevated on all the 3 occasions, with the highest being 4.1 nanomole per liter, and SHBG was low, and free androgen index was high, and the elevation of testosterone was not in the tumoral range. Then we come to DHEAS sulfate. This elevation is definitely way too high in the tumoral range in all the 3 occasions, with the highest being 26 micromole per liter, which corresponds to 958 microgram per deciliter. So it is significantly more than 19, and this warrants an imaging for adrenal to rule out neoplastic etiology. Then we did 17-hydroxyprogesterone on 2 occasions. It was 5.4 and 5.5 nanomole per liter, which suggests there is still a need to rule out non-classical congenital adrenal hyperplasia because the values were more than 5.1. And these were ultrasound pelvis showed bilateral polycystic ovarian morphology. We did a short synaptic test to rule out non-classical congenital hyperplasia due to 21-alpha-hydroxylase deficiency. You can see in both in 30 and 60 minutes, the value of 17-hydroxyprogesterone was less than 30. So this was not suggestive of non-classical congenital adrenal hyperplasia. Because she had a DHEAS in the tumoral range, we did a triple phase CT of adrenals. You can see all the three phases. It was reported there is a lesion in the body of left adrenal gland of 7.7 millimeter, and the right adrenal gland was reported normal. It had a pre-contrast HU of 24 with a post-contrast enhancement of 114 and delayed phase of 72. With an absolute washout of 47.8 and relative washout of 37.9 suggests the lesion is a lipid poor lesion. Now to summarize, we have a 21-year-old female with secondary amenorrhea since age of 14 with history of hirsutism and physical finding of mild clitoromegaly. Laboratory results were consistently showing very high DHEAS in tumoral range, and also there was raised free androgen index. But the chronicity of presentation is not suggestive of a malignant etiology because her presentation is over the years. It's not a sort of an acute, sudden, short presentation over months. And imaging showed a polycystic ovarian morphology, and there is a lesion of 7.7 millimeter lipid poor lesion in the left adrenal gland with a baseline HU of 24. And a baseline, though our baseline 17-hydroxyprogesterone was more than 5.1, but the synaptic test was not suggestive of non-classical congenital adrenal hyperplasia. Now, can we have the poll question, please? So, given this clinical and biochemical profile and imaging findings, what you think the most likely diagnosis in this case? Do you think it's a PCOS or other rare forms of non-classical congenital adrenal hyperplasia, which because we did rule out 21-alpha-hydroxylase deficiency, but are you thinking of other rare forms? Or do you think this adrenal lesion is the reason for the current symptom? Or do you think there's a small virilizing ovarian tumor causing the symptom? Can we have the poll question, please? Shall we have the answer? Wow, like 23% people suggested it could be PCOS, and there was 21% suggested that it could be other forms of non-classical congenital adrenal hyperplasia, and 45% were in favor of the adrenal lesion being the cause for a current symptom, and 11% answered for ovarian tumors. Okay. Now let's just review the following parts in the literature that could be relevant in our case. Try to understand more about our case. So let's just see about hyperandrogenism in female in general, about the causes and how do we approach overall. Now, how to explain the adrenal lesion in this case, whether it's just a cause of the patient symptom or it's a bystander effect. Then we'll just learn a little bit deeper into the functional phenotypes of PCOS. We know about the clinical phenotypes. So this will try to understand our case much better. Then we'll learn about how to localize the source of androgen in such challenging clinical scenarios where the source of androgen is from adrenal or ovarian. Now, this pie chart shows the distribution of androgen disorders in women. You can see almost 3/4 of all cases are due to PCOS. Now, this is followed by idiopathic hyperandrogenism, which constitutes around 15.8% of cases, in which you have biochemical and clinical evidence of hyperandrogenism, but patient have normal ovarian morphology with normal ovulatory function. Next comes idiopathic hirsutism, which constitutes around 7.6% of cases, where only the patient has hirsutism, but there is no biochemical hyperandrogenism or ovulatory dysfunction. Next, we have non-classical congenital adrenal hyperplasia, which is 4.3% of cases. And then we have rare causes, which includes androgen secreting tumors, enzyme deficiencies, and other genetic disorders, which constitutes around 0.2% of cases. Now, we know that PCOS is a diagnosis of exclusion. We don't diagnose a PCOS, but rather we exclude a certain list of disorders, and then you come to the conclusion that the patient is having PCOS. Of that, the foremost thing is non-classical congenital adrenal hyperplasia, which is unlikely in our case because we did synactin test, which is negative for 21 alpha hydroxylase deficiency, but we also did a comprehensive CAH genetic panel, which was also negative. So this is unlikely in our case. Hyperprolactinemia, hypothyroidism, and obesity as a cause of androgen excess. Again, clinically and biochemically, this is excluded. Then we have Cushing's, acromegaly, and glucocorticoid resistance syndrome. Clinically, biochemically, there were no features to suggest these things. We had normal IGF-1, ATM cortisol, and ICTH was normal, and the cortisol was suppressed by overnight dexamethasone suppression test. So again, these causes were ruled out. Then we are left with ovarian hypertrichosis. Again, the patient did not have testosterone in the range of ovarian hypertrichosis, and the age of presentation is usually in the postmenopausal age group. So this is also unlikely. Then we have neoplastic etiology. Here we had the patient clinical symptom of clitoromegaly, which suggests sort of a severe hyperandrogenism. And also we had a biochemical evidence of DHEAS in the tumoral range. And we did find a lesion of 7.7 millimeter in the left adrenal gland. So at this point, this diagnosis could not be ruled out. Pregnancy-related issues causes, again, no. Drugs or androgenic causes, there is no history to suggest this. Idiopathic hirsutism, again, no, because we have biochemical evidence of hyperandrogenism. Idiopathic hyperandrogenism, again, no, because the patient has ovulated dysfunction, which rules out this possibility. So at this point, we are stuck with ruling out this neoplastic etiology because of certain clinical and biochemical and imaging findings. Now, this slide shows what are the indications for urgent imaging for adrenal and ovaries in a case of hyperandrogenic state in females. When the symptom is very rapid onset and progression over 3 to 6 months is one of the indication, and signs of overt virilization like deepening of voice, breast atrophy, clitoromegaly. And biochemically, if the testosterone is more than 5 nanomole per liter, which corresponds to more than 200 nanogram per deciliter, or DHEAS more than 19 micromole per liter, which corresponds to more than 700 microgram per deciliter. If these features are there, then definitely there is a need to do a structural imaging to rule out neoplasm of adrenal or ovarian in origin. Now, coming back to our case had a DHEAS in the tumoral range on multiple occasions. Patient did have clitoromegaly, but the symptoms were not short or acute, but rather it was over the years. So we are not thinking something which is an aggressive malignant cause, but we could think something of a smoldering, an adenoma or benign sort of a lesion. So this slide shows the neoplastic causes of adrenal androgen in women. The sources could come from adrenal or ovary. In adrenal gland, we have adrenocortical carcinoma and adrenal adenoma. And these are the list of ovarian tumors that can secrete androgen excess. Because DHEAS is the primary source of androgen that we are concerned in this case, so our cause is likely to be limited to adrenal gland. And because the presentation, as I said, is not a short acute, then we think of more of an adenoma or a very benign etiology. So in this context, so there is an entity called as pure androgen secreting adrenal tumor. It's not a clinical entity per se, but it's a subtype of adrenal cortical carcinoma or adenoma, where the tumor secretes only adrenal androgen, but not other cortical hormones. So it's a very rare subtype, and it has a bimodal distribution of age with peaks in third decade, the benign forms, and the malignant forms in the fifth decade. And patients have high level of DHEAS and or testosterone. And malignancy occurs in almost 26% of such adult cases. And it usually correlates with increased size and rapid course. And many times these tumors are misdiagnosed as PCOS and managed as PCOS. So whether our patient has this or not is a question to be answered. Now let's flip the coin to other side. Can this adrenal lesion be just a bystander in the case of severe PCOS? First, what we should know is the non-functional adrenal tumors or incidentalomas are extremely rare in young individuals. And the incidence is less than 1% in those less than 18 years, and it's 0.2% in 18 to 25 years. As opposed to middle age, it is almost 3 to 4%, and with population more than 65 years, it's 7 to 10%. So we have to keep this also in mind while interpreting the clinical case scenario. So adrenal non-functioning adenomas or incidentalomas are very rare in children and young adults. Now let's dive into PCOS phenotypes. First, we'll deal with the slide which deals with clinical phenotypes of PCOS that we are all very familiar. We know there are 4 clinical phenotypes of PCOS. Like this depends on the combination of hyperandrogenism and hirsutism, or ovulatory dysfunction or polycystic ovarian morphology. If someone has all the three, we say the patient belongs to phenotype A, which is a sort of severe phenotype. If there is a combination of hyperandrogenism and ovulatory dysfunction, then it's phenotype B. If there is a combination of hyperandrogenism and polycystic ovarian morphology without ovulated dysfunction, then it's phenotype C. And then we have phenotype D, which occurs in 20% of cases where there is no hyperandrogenism or hirsutism, but rather there is a combination of ovulated dysfunction and polycystic ovarian morphology. Understanding this clinical phenotype is important because it helps us to guide a personalized treatment approach. Because for phenotype A and B, it's more of the metabolic health comes as a priority, whereas for C, it's more of androgen control to control the patient's symptom. For D, it's more of menstrual cycle regulation. So understanding this phenotype helps us in treating the patient. Now let's dive a little deeper into the functional phenotype, which may help us to understand our patient better. See, functional phenotypes are the phenotypes which are named after the source from which the androgen is produced in the PCOS. For example, if the source of androgen is from ovary, we can label it as functional ovarian hyperandrogenism. If the source is from the adrenal gland, then we label it as functional adrenal hyperandrogenism. Before going into these phenotypes, let's just revise the physiological source of different androgens in women. Testosterone, we know the almost 50% contribution of circulating testosterone in females comes from peripheral conversion of androstenedione, and rest 25% equally from ovary and adrenal contribution. DHEAS, almost 95 to 100% is from the adrenal. So it is one steroid which is exclusively produced by adrenal gland with negligible contribution from ovary or peripheral conversion. Androstenedione, it is contributed almost equally from ovary and adrenal gland with almost no contribution from the peripheries. Dehydroepiandrosterone, it has a contribution predominantly from adrenal gland, that is 50%, and 20% from ovaries, and 30% from peripheral conversion of DHEAS to DHEA. Then we come to dihydrotestosterone. The contribution is from only periphery but not from other sources, where testosterone is converted into DHT by 5-alpha reductase. Now let's go into the functional phenotypes. So this was taken from the article published by Rosenfeld way back and its colleagues way back in 2011, where they tried to classify the functional phenotypes of PCOS with respect to the source from which the androgen is produced. Initially, they classified the phenotypes into two groups, that is functionally typical PCOS and atypical PCOS. This functional typical and atypical PCOS depends on whether the patient has the intrinsic dysregulation of 17-alpha hydroxylase activity in the theca cell of ovary. We all know one of the key things that drives the androgen source in the PCOS is presence of intrinsic defect in the theca cell, where there is a dysregulation of enzyme 17-alpha hydroxylase and 1720 lyase activity, which leads to increased conversion of progesterone and pregnenolone into 17-hydroxyprogesterone and DHEA. So that's how the androgen excess is produced from the ovaries. If we can demonstrate this defect, then they put the patient as a typical PCOS. How did they demonstrate? By doing a GnRH agonist test with leupride or nephrilin, and they took the sample for 17-hydroxyprogesterone from baseline and after 24 hours. If after 24 hours, if there is an exaggerated 17-hydroxyprogesterone rise, they suggested it is a functionally typical PCOS. This is not done routinely in clinical practice, so this is done in the research mode. So now coming back to this classification again, so what you can see is functional ovarian hyperandrogenism, which constitutes almost 90% of all cases of PCOS. So in 90% of cases of PCOS, we tend to find the ovaries is the source for androgens. So it could be typical or atypical. As I mentioned earlier, this is with respect to the response of 17-hydroxyprogesterone to GnRH agonist. So it is typical in 67% of cases and atypical in 20% of cases where there is no response. Now coming to the adrenal component. So this is called as functional adrenal hyperandrogenism, as I discussed before. So this could be, like most of the time, it coexists with the ovarian source. That is almost 30% of cases of functional ovarian hyperandrogenism, they have a source from the adrenal gland also. But very rarely, in 5% of cases, we have an isolated functional adrenal hyperandrogenism where the source of the androgens is only from adrenal gland but not from ovaries. which I marked here. Then we have atypical PCOS of obesity where the source of androgen is from the adipose tissue where the conversion takes place. And then we have a very rare phenotype where idiopathic, it's called as idiopathic atypical PCOS, which is less than 1%, where the source could not be explained. So having understand that this, now let's go into the dynamic test that we use to localize the source of androgen in clinical settings. So we have 4 tests. One is dexamethasone androgen suppression test or DAST. This is like after dose of dexamethasone, then we expect the adrenal androgens to get suppressed. So it helps us to localize the source of androgen to adrenal gland. Then we have GnRH suppression test where because the ovarian steroids are under the influence of GnRH, so with GnRH agonist on prolonged phase, it will lead to suppression. So again, it helps us to say the source is from the ovary. Then we have short synactin test. We do generally for to rule out non-classical congenital adrenal hyperplasia, but sometimes to say that the source is from adrenal gland also, we can use it. And last is simultaneous adrenal and ovarian vein sampling. When we could not localize the source with all these tests, then we can go for this. Remember one thing, this dynamic test will bring a response only in a functional cause of androgen overproduction. An overt malignant cause will not show any response to these tests. So this should be in our back of mind while using this test. Now, when to perform these tests in a clinical setting? So when we have a patient where the clinical and biochemical features do not align with standard PCOS or CAH, and if there are no lesion in imaging, but despite you have a very strong clinical and biochemical suspicion of a tumor, you have a lesion in the adrenal or ovary, but you are not very sure whether that lesion is a source of androgen that is seen in the blood. So in all these situations, we can think of doing this dynamic test. So in our patient, we can have these 2 criteria fit in because we don't have a clinical or biochemical features that fits in a typical PCOS or a CAH. And we do have an adrenal lesion, but we do not know whether that lesion is the one which is secreting or it's just a bystander in the face of a severe typical PCOS. And we should also know when not to perform this testing. Like it should not be done routinely in clear case of PCOS where doing these tests is not going to change the management. And when we have a very clear adrenal mass or ovarian mass matching with the biochemistry, do not waste time in doing these tests, just directly go for surgery. And when there is an isolated DHEAS elevation, there is no point in doing these tests because as we discussed before, DHEAS is one steroid where it is produced exclusively from the adrenal cortex. So there is no need to demonstrate the location of these androgen. Last is baseline. To start with, if the baseline LH and FSH are already suppressed, there is no need to go for GnRH testing because already it shows the androgen which are present or independent of gonadotrophins. Now coming to the first test, that is dexamethasone androgen suppression test or DAST. There are multiple protocols are there. The short test, which is 4-hour test, where you give a dose at 12 p.m. and take the sample for androgen at 4 p.m. And then we have a 2-day test where we give 0.5 milligram dexamethasone over 6 hours for 2 days. You take a sample at day 1 and day 3. But the third one is a standard test where 4-day test. This is where people, most of the part of the world, they practice this test, where 0.5 milligram of dexamethasone is given over 6 hours over 4 consecutive days, and you take a sample on day 1 and see the suppression on day 5. Last is an extended way of doing the test where you do the test over 6 days. Now, how to interpret the test? Like if at the end of your test, if the suppression of testosterone is more than 40% or DHEAS suppression is more than 50%, then the cause of androgen is ACTH dependent adrenal hyperandrogenism, likely functional. So it goes against a malignant etiology. These cutoffs are not very clear cut because different sources use different cutoff, and there is a cutoff of even suppression of DHEAS more than 75% also. Now coming to the testosterone, if at the end of the test you find the testosterone levels remains elevated and there is no change in that, it says the source of the testosterone is from the ovaries. If the testosterone is suppressed but the suppression level does not reach to less than 40%, then we can say the source is likely combined from ovary and adrenals. So we did 4-day DAST test for our patient, and these were the results when taken at the baseline, and this is after the 4th day. What we found out is that testosterone is suppressed more than 32%. and DHEAS suppression was more than 75%, and free testosterone suppression is more than 36%. So this suggests the patient's DHEAS elevation is non-malignant or functional, and the testosterone is likely a combined source, as though it is suppressed, but the suppression limit does not cross more than 40%. I have a question here is, now in our case, if you assume that the lesion in the adrenal gland is the one which is producing DHEAS, like a small adrenal lesion which is likely benign, or because of the way the patient presented with, can DHEAS from such small adrenal adenoma can be suppressed with such a prolonged 4-day dexamethasone suppression test? So this is one of the key questions in our mind while interpreting the result in our patient. I'll just run through the other dynamic test before I conclude. So we have gonadotrophin releasing hormone suppression test. So this is where we give a depot of triptorelin or lipirelin, and we take a sample at day 1, day 0, and also 28 days after injection. If there is a suppression of testosterone more than 50%, it confirms an ovarian source. Then we have short synactin test. Generally, we do it to rule out CAH. So we know this cutoff of 17-hydroxy progesterone value of more than 30 is suggestive of non-classical congenital adrenal hyperplasia secondary to 21-alpha hydroxylase deficiency. And again, there are other rare forms like 3-beta-HSD2 deficiency. Here, the 17-hydroxy pregnenolone levels are more than 10 standard deviation. If it's 11-beta-hydroxylase deficiency, here 11-deoxycortisol response is more than 5 times of upper normal limit. Now here we are talking about non-classical forms. And very rarely we can use this test to demonstrate an hyperresponsiveness of DHEAS to say that the DHEAS is of adrenal source. If we cannot localize the source of steroid with all this what we have discussed, the last resort that is left out is doing a simultaneous adrenal and ovarian vein sampling. Here we can analyze both the adrenal and the ovarian veins and look for the gradient to demonstrate the source of androgens. To validate for cannulation, the estradiol in the ovarian vein should be more than 2 times of that of periphery. For adrenal vein, like baseline cortisol should be more than 2 times, and post ACTH should be more than 5. To localize in general, if the testosterone either from ovary or testis in comparison to periphery it's more than 2, then it's significant. If you are suspecting a tumor, then if the gradient should be more than 2.7, and there are even ratios to lateralize which side it's coming from also that I have not discussed here. Now, let's come back to the case and I will conclude here. Now, these are the key issues that we felt like as a diagnostic challenge in our case. What should we label this case? Whether it's a PCOS, which is a severe form with a non-functional adrenal lesion, or should we say the patient is having a pure androgen secreting adrenal tumor, or do you think any other workup should be done to arrive at conclusion? And what about this left adrenal lesion and how the follow-up should be done radiologically, and how long you recommend us to do? In what scenario you will consider removing this adrenal lesion? As the patient, as I told it before, the patient has severe secondary amenorrhea since menarche and bleeds only with progesterone. Last, I would like to take your comments on dynamic testings in workup of hyperandrogenism, like the cutoffs and other things that you use in your practice. So with this, I will conclude. I'll give over to Professor Young. Thank you.
Thank you, Dr. Morgan, for sharing your challenging case and the question you have regarding the management and the follow-up of this case. So we would like to hear Dr. Young commentary about the case and how we would have pursued and how he would like to follow the case in that kind of biochemistry and the clinical presentation of this young female who is thin, lean, and she has secondary amenorrhea with very high isolated DHEA levels. So Professor Young, can you please share your thoughts?
I'd be happy to. Clearly, the theme today is diagnostic conundrums. I mean, these are challenging cases, another excellent presentation of a challenging case. I'm just going to share my screen. I just have a couple slides I want to show. So this is a book that we published a couple of years ago, 100 cases from the Adrenal Clinic. And case number 88, I titled this one DHEA sulfate, the love it or hate it hormone. And why I called it that is I like DHEA measurement, sulfate measurement, in a patient with an adrenal incidentalloma because it's a really good screen for whether that adrenal incidentalloma is autonomously producing cortisol. So men and women make DHEA, reference ranges are different based on sex, they're different based on age, but we all make it because of ACTH secretion. If a patient has a cortisol secreting adrenal adenoma, and if that cortisol secretion is clinically important, it's going to suppress ACTH and it's going to suppress DHA sulfate. DHA sulfate has a 10 to 14 hour half-life, so it's stable throughout the day. ACTH, as you all know, is fluctuating minute to minute. So ACTH is not very reliable, but DHA sulfate is like our adrenal glycosylated hemoglobin. It tells us whether the pituitary is making ACTH and whether the adrenal is seeing ACTH. So when DHA sulfate is low in a patient with adrenal incidentalloma, that's highly suggestive that they have this cortisol secretory autonomy that some people call mild autonomous cortisol secretion, MAX, others call subclinical Cushing's. So it's a good screening test for that. Whereas if the DHA sulfate is, I'll use conventional units, if it's above 100 micrograms per deciliter, the chance that patient has clinically important cortisol secretory autonomy in the setting of adrenal incidentalloma is very low. So that's why I like measuring DHA sulfate. When do I not like it? In evaluating women with hirsutism, it's very common and appropriate to measure testosterone DHA sulfate in women with hirsutism. DHA sulfate is very commonly elevated. Now, it's usually not as elevated as in the case we're discussing, but it can be fairly moderate elevation, 500, 600 microgram per deciliter. And the question always is, does the patient have an adrenal tumor? Does the patient have adrenal cancer? So in this particular chapter, we highlighted the use of a different version of the dexamethasone suppression test that has been discussed so far today. And there's many ways to do this, and they're all fine to use. We do it a bit differently. We simply give 0.5 milligram of dexamethasone at bedtime for 7 days. Measure DHA sulfate before, measure DHA sulfate the morning of day 8. And if it drops more than 50%, that tells you the source of production for DHEA is not a tumor, but it's physiologic or an abnormal physiologic type of production of DHEA. And I'll come back to what that may be in a minute. And that's what we highlighted in this particular chapter. So let's come back to our case. So we were told that genetic testing for congenital adrenal hyperplasia was negative. And this is important because when you do a cosentropin stim test for 17-hydroxyprogesterone, you're really only screening for the most common form of CAH, and that's 21-hydroxylase deficiency. But when you do genetic testing, you're screening for all forms of congenital adrenal hyperplasia. So we know it's not a genetic cause, but it could be something related to that, and I'll come back to that in a minute. The second issue, and it's similar to the first case we discussed today, this patient has an 8 millimeter left adrenal nodule that apparently is lipid poor, 24 Hounsfield units. And we were given some washout data. I will share with you that although early on in the story of adrenal incidentalomas, we're talking about in the early 80s, mid 80s, percent contrast washout was thought to be helpful to distinguish between benign lesions and malignant lesions, between benign lesions and pheochromocytoma. and so on. But now with so much more experience, we're realizing that percent contrast washout is not very helpful at all. Pheos can wash out slow, pheos can wash out fast. Benign adenomas can wash out slow, they can wash out fast. So personally, I ignore washout data. I think it's all about the unenhanced CT attenuation. And in this case, we have a 20-year-old woman with a lipid poor nodule. Now it's very small. It's 8 millimeters. And on the slice we were shown, it was actually hard to discern the borders of the nodule. So that clearly deserves some follow-up. I would not ignore that. It'd probably be reasonable to image with a non-contrast CT, or if you want an MRI, in about 6 months. And if it's unchanged, perhaps a year after that. And what I'd do at that point, I don't know. I'd have to see what's going on with the patient. But I don't think the nodule is the source of DHEA, and I'll come back to this in a minute. Oh, the question was about, there was a question about doing adrenal vein and ovarian vein sampling. And we certainly do that. We have a protocol for that at Mayo Clinic. We probably do it 6 to 8 times a year. And it's mostly in women who have markedly elevated testosterone levels and normal appearing ovaries and perhaps even an adrenal nodule. In almost every case, when it's testosterone, it has proven to be a ovarian cause. When it's a postmenopausal woman with elevated testosterone and the adrenal glands appear normal, it's almost always going to be hyperthecosis. And you don't need adrenal vein and ovarian vein sampling to prove that. So what I think most likely is going on here, because this young woman's DHA sulfate did suppress more than 50% with dexamethasone, suggesting if you suppress ACTH, the source of DHA sulfate stops making so much DHEA, and therefore it's under ACTH control rather than a tumor. If a tumor is making DHEA, it shouldn't care if ACTH is around or not. I mean, that's the general concept behind the dexamethasone suppression test for DHEA. So what we have found in young women like this, where the genetic testing's negative, if you do a cosentropin stim test, and instead of measuring 17-hydroxyprogesterone, you measure 17-hydroxypregnenolone, which is proximate to the 3-beta step. And if you measure DHEA, not DHA sulfate, but DHEA sulfate, remember, it's got a long half-life, and we're going to do a short dynamic test. You want to measure the short half-life version, which is DHEA. Usually you will demonstrate an inefficiency at the 3-beta step. Now, it's not a genetic cause. It's probably a cofactor. We don't know what it is, but it's actually not a rare thing. And it's a fairly, I wouldn't say common, but we see this a fair amount in women, premenopausal women who have high DHA sulfate. And that's why you can suppress them with exogenous glucocorticoids. So that's probably the one additional test I would do in this patient. And because you already showed that DHA sulfate can drop with glucocorticoid administration, usually we offer these women low-dose glucocorticoid, just like you would do in a patient with congenital adrenal hyperplasia, not as high a dose. If you're going to use prednisone, maybe 2 milligrams of prednisone every morning. If you're going to use hydrocortisone, maybe 10 or 15 milligrams of hydrocortisone every morning. And then you simply monitor DHA sulfate. All you want to do is normalize DHA sulfate. And whatever signs and symptoms DHEA excess was causing should resolve. And in this case, secondary amenorrhea. So that's what I view as the next steps. Let's see, there are a couple other questions here. Oh, we talked about that. Oh, when would I consider removing it? obviously, if DHEA didn't suppress with dexamethasone, then I think you would have a good argument to consider resecting this 8 millimeter nodule. But since it's suppressed with dex, I'd probably observe it for now, and I'd probably go the route with exogenous glucocorticoid treatment and see what kind of benefit we achieve.
Thank you, Professor. I just have a question here. Like for Cushing's evaluation, if there is a small adenoma in the pituitary, though it is an adenoma which is producing the ACTH, but to high dose it gets suppressed. So it's not. Can we incorporate the same thing to the current slow-growing adenoma with giving dexamethasone for 5 days? Can it get suppressed?
If it's truly a tumor source of DHA production, it shouldn't be dependent on ACTH. You could argue that perhaps you're suppressing the non-tumor part of the adrenal that's making DHEA, but you wouldn't think it'd be making DHEA if a tumorous part of the adrenal is making excess DHEA. But to be honest, I don't have a experience-based answer on this. We know that other tumors, for example, DHEA secreting adrenal cancer, they don't suppress DHEA when you give them dexamethasone. But if it's a benign adenoma, I'm not as certain. The other comment I would make is we're talking about an 8 millimeter nodule. That's a mighty small factory. And I think it's very unlikely it's responsible for this level of DHEA secretion.
Thank you, Doctor.
Thank you, Professor Young. I have a few questions from the attendees, and I think we have a little time to just ask attendees asking when to think of glucocorticoid resistance syndrome in this scenario.
When to think of glucocorticoid resistance in this scenario. Right. So with glucocorticoid resistance, you see a couple things. You see hypertension, because what happens, so basically there's a mutation that has affected the glucocorticoid receptor. So to partially activate the glucocorticoid receptor, these people have to make a lot of ACTH and make a lot of cortisol. In the process of making a lot of cortisol now has access to the mineralocorticoid receptor, and also you're making excess deoxycorticosterone because of cholesterol coming down through both pathways. So typically these patients are hypokalemic, they're hypertensive, and that's not the story with this patient. I mean, this patient's presentation is secondary amenorrhea with hirsutism, but nothing for hypertension or hypokalemia. So, yeah, I think that's glucocorticoid receptor issues are something to consider when you have high cortisol levels, but not Cushing's, and you have hypokalemia and you have hypertension.
Exactly. The clinical position is absolutely different from the usual glucocorticoid resistance syndrome. And the question is, Dr. Young, is that if it would have been an androgen-producing tumor, then LHFSH should be low in this scenario. So are we safe to label this case as polycystic ovarian disease with functional hyperandrogenism, or rather we should still think of it that we need further dynamic testing and check the DHEA level with the cosinotropin stimulation test?
Yeah. I mean, I agree with the person that made that comment. Typically, especially if you have a testosterone secreting ovarian tumor, you expect LH and FSH to be low. I mean, and the levels that were shared with us actually looked a little more like PCOS than anything else because LH was higher than FSH. Clearly, if this patient were to have PCOS, it's an atypical form. Her BMI is 17.7, so she's quite slender. My money's still on, I think most of the signs and symptoms here are not PCOS, but rather related to high DHEA. And if I was seeing this patient, yes, I would do my next step would be a concentropin stim test for DHEA. Again, not DHA sulfate, DHA and 17-hydroxypregnenolone. And if you saw marked increases in those two values, it would support the concept that that's what's going on here. There's an inefficiency at the 3-beta step, and that by giving exogenous glucocorticoid, it should reverse the high DHA sulfate.
Yeah, thank you so much for your input, Dr. Young. And I think we have one comment from Dr. Yasser Hassan, who is also an expert in the case of hyperandrogenism, and he agreed with the management plan. And same thing, that in rare scenario of androgen-producing bilateral micronodular hyperplasia, which we sometimes do not see, and we can still manage with a small dose of dexamethasone, because this patient is again under active surveillance, and she still have the issue and concern mostly about her secondary amenorrhea, because hirsutism she is managing with other measures. And she doesn't want to continue on OCPs. She just like to take progesterone for her withdrawal bleed. And whenever she attends the clinic, she asks the same question, that what is my definitive management? And I'm young now. What is the, like marriage perspectives, and what would be the answer for that? So I think we can right now offer her as a follow-up plan that we will see if DHE is available for us. We do repeat the cosinotropin stimulation test and check the response, and probably we give a trial of low-dose dexamethasone for her symptoms without progesterone. And we have already scheduled one MRI for her in coming month, so we can see the progression, if there is any, in the size of the small adrenal adenoma. So I think it sounds good for now regarding the management of this case, because she was not really typical PCOS morphology as well as the biochemistry, unlike to the other PCOS cases.
Yeah, I agree. I think that sounds like a good plan.
Yeah. Okay, I think we do not have any more questions regarding any of the previous and the current case from the audience. So I really have my heartfelt gratitude for the speakers, attendees, and we are really honored to have Professor Young today and share his thoughts and expertise, because this is how we try to hold this platform for sharing of the ideas, knowledge, and spread the word across the endocrinologist and the internist and physician who are interested in managing these cases. So we can move now to our another session for today, because this is a symposium, and we are having the Ricordatis patronage for the Professor Anthony Tabarin. He's Professor of Endocrinology at University of Bordeaux and Head of Endocrinology at CHU, France. He's an international authority in Cushing syndrome, adrenal tumors, and pituitary disorders. He is co-authored of major international guidelines, including the Endocrine Society 2015 and Pituitary Society 2021 guidelines for Cushing syndromes and the disease. He's a renowned clinical scientist with extensive contributions to clinical research in adrenal and metabolic endocrinology. So Professor Antoine will share with us the lecture about efficacy and safety of osilodrostate in various etiologies of Cushing syndrome. So Professor Anton, please, you can start your presentation now.
Okay, thank you very much for this very kind introduction. I will try to share my screen now. So do you see my slides?
Yes, we do.
Okay, thank you very much. So thank you for the invitation, and thank you to Ricordati for sponsoring my presentation about osilodrostat. So here is my disclosure. So You know that whatever the cause of Cushing syndrome, the two main goals of the treatment, as recommended in the guidelines of the Endocrine Society, are to treat the comorbidities like hypertension, diabetes, and so on, and also to remove the tumor, whether it's an adrenal tumor, an ectopic OCTH-secreting tumor, or a pituitary tumor. But you also know that sometimes surgery is not possible or fails. And in this instance, you have to use palliative weapons. Among these features steroid inhibitors, which are probably the most widely used drugs to lower cortisol secretion. So here is a very schematic image of the various steroid inhibitors that are currently used. And you can see here on this slide that osilotrostat targets the same, or is supposed to target the same enzymes as metyrapon, namely the last step of cortisol and aldosterone synthesis. The main difference between metyrapon and osilotrostat are in terms of affinity for these enzymes, and there is a higher affinity of metyrapon, of osilotrostat, sorry, over metyrapon. So it means that the drug may be more potent, and it represents in practical terms less pills. And the drug also has a longer half-life, so it means less intake per day. So you know that Recordati has conducted an extensive clinical program, research program with this drug, with namely the LINK-3 and the LINK-4, two pivotal phase 3 study that conducted to the availability of the drug on many markets. So I will go very rapidly because I'm pretty sure that everyone knows the main results of these trials. The LINK-3, you have here the degree of control of UFC after 12 or 14 weeks of treatment with the drug. And this trial had a very specific protocol with, after reaching the control of UFC, a randomized withdrawal period of 8 weeks. And this was the main objective of the study, main endpoint. And of course, the control was maintained in a more significant number of patients taking the drug as compared to those who were switched to the placebo. And in line with this improvement in biochemical parameters, of course, many symptoms were also improved, like weight and here in blood pressure. Many comorbidities of Cushing were improved. In terms of side effects, some important side effects were to consider. As you can see, the most frequent one, although it was rarely severe grades, was AI related to hypocortisolism, which is namely with different names in this graph. You can see here, and I will come back on this, that the side effects related to the putative accumulation of precursors upstream as the enzymatic blockade was rather low, with around 10% cases of hypokalemia, hypertension, and less than 10% case of excessive androgen impregnation, like acne and hirsutism. So hypocortisolism and adrenal insufficiency is probably the main side effect of the drug, which is also, of course, related to its potency. But I want to emphasize one point, is that in this study, LINK-3 and LINK-4, it was not mandatory to measure ATM serum cortisol at the time of these symptoms. And so maybe this number is a little bit overestimated, because as you know, there is a differential diagnosis with adrenal insufficiency, that is glucocorticoid withdrawal syndrome. So GWS occurs usually quite soon, in days or weeks after a dramatic fall in cortisol level in a patient who had previously sustained hypercortisolism. And we know that GWS has a number of common symptoms with AI, like asthenia, like muscular pain, fatigue, and so on. So, of course, you have to know the more specific symptom of AI, like hypotension, like hypoglycemia, like vomiting, which clearly couldn't be related to GWS. And we also know that the timing of occurrence of this symptom is important, because if this symptom occurs more than 6 months after the decrease in cortisol level, it's not GWS, it's adrenal insufficiency. So with regard to these side effects, there are key points to consider. I think it's very important to explain how serotonin inhibitors work, how you can differentiate GWS from adrenal insufficiency. Of course, educate your patient with regard to the situation in which it can occur, educate them on the symptoms, on the signs. I always prescribe to my patient receiving osilodorstat a prescription of hydrocortisone pills, an injection kit to take when there is suspicion of AI. Also, I think it's very important, whatever the biochemical parameter you follow for the control of hypercortisolism, like UFC or late-night cortisol, it's important also to measure morning serum cortisol regularly, because we know that UFC is not a sensitive marker to diagnose adrenal insufficiency. And then it's important also to reassure this patient, because AI is just a reflection of the potency of the drug. And to be honest with you, I think it's important in such a devastating disease like Cushing syndrome to have a drug that is able to induce adrenal insufficiency, because it means it works. But in the LINK study, we know that less than 6 or 7%, less than 7% of patients discontinued the drug due to AI. Link 4 was a upfront drug versus placebo double-blind study. And of course, you can see here in this study, patient with only Cushing's disease, the rate of control was more than 70% of patients, although we have to consider that the intensity of hypercortisolism was a little bit less in this patient than in those of the LINK 3 study. And you can see here the control with time. So you can see the drug is acting quite rapidly. And even at week 2, 25 of patients were already controlled at week 2. And also in terms of adrenal insufficiency, you can see here that the prevalence of adrenal insufficiency during the titration period was lower in the LINK 3 than in the LINK 4 study. And this may be related to the fact that the increment in osilodorstat dosage was made slower in the LINK 3, in the LINK 4 study as compared to the LINK 3. In the LINK 3, it was every 2 weeks, while in the LINK 4, it was every 3 weeks. So probably this slower rhythm of increase in the drug dosage induced less adrenal insufficiency. And despite a slower rate of increase, you can see here that the median time to reaching the first normalization of UFC was quite similar between the two studies. Recordati has also collected the data from the patient included in the LINK 2, LINK 3, LINK 4 study that received the drug for a longer period. And you can see here that in the LINK rollover study, including 127 patients, the median osilodorstat exposure was 5 years. So of course, there is a bias in this study because, of course, the patient who continued with the drug for a long time were patients that were equilibrated with the drug. But what you can see here is that the mean UFC was still controlled over all these years. And the major information to be drawn from this study is that the escape phenomenon seems to be very rare with this drug. So this is an important point for mid to long-term treatment. What we also know in terms of clinical symptoms during the extension phase of the LINK 3 study in this case, you can see that there is an improvement with time about the symptom. But I want here to focus on the red dashed line to see here that hirsutism in female also improve with time. So this might be a little bit counterintuitive because since this drug blocks the last step of cortisol synthesis, and since ACTH increases with the drug, you may expect adrenal androgens to increase and so hirsutism to appear or to worsen. And this is exactly the inverse that was observed. And indeed, something quite unexpected from what we know from in vitro study with the drug is that the testosterone level at start increases as expected after the introduction of the drug. But you can see here that in the mid to long term, the testosterone level in female decrease. So of course, you also see the error bar. So it's not the case of every woman, but in a number of these, after a transient increase in cortisol, in testosterone level, then testosterone decrease. And this may explain this low rate of hirsutism and even the improvement in hirsutism. This was a totally unexpected effect, and I don't have time to go more deeply in the mechanism for this phenomenon, but we suppose now, according to this clinical observation, that the drug probably acts at other levels of cortisol steroidogenesis than the CYP11. And also, I want to make a note about adrenal insufficiency, because I've shown previously that adrenal insufficiency, these are the red bars here, occur mainly during the titration phase, especially if you titrate too rapidly. But you can see here also in this slide that it occurs also on the long term and long-term treatment. And it can occur despite any interferent additional disease. So you have to know, this is also a specific thing of this drug, is that it has a sustained effect and maybe an increased power with time, with prolonged impregnation of the drug. And in the LINK-3 and LINK-4 extension study, the dosage of osilodrostat had to be decreased with time. So we have to be aware of this possibility of a long-term, mid-term onset of adrenal insufficiency in patients previously controlled. And this is why I think you have to educate your patient and also regularly check from time to time on a systematic way your ATM serum cortisol to diagnose adrenal insufficiency. This is just, I would say, kind of proof of concept limited study, but that is interesting, performed in only 16 patients by an Italian group, patients that received, I would say, a rather small dosage of osilodrostat. So patients were controlled with a rather small dosage, and they were taking the drug twice a day as recommended by the company. So the investigator decided to give the same amount of 24-hour drug dosage, but to give it only in the evening. And they followed patients with serial salivary cortisol measurement. And you have here the curve of what happened. You can see here the blue curve. This is when the drug was taken twice a day. And then in red, the curve of salivary cortisol when it was taken only in the evening. And you can see 2 points, is that first, the nadir of cortisol at midnight is lower in patients with only the evening intake, without inducing on the next day adrenal insufficiency. And in parallel with this improvement in late night salivary cortisol, a patient describe an improvement in quality of life and also in quality of sleep. So maybe we need more studies on this point, but maybe at least in patients receiving rather low dosage of the drug, it can be useful to try to restore as much as possible the circadian rhythm of cortisol, to give the drug only in the evening. So now I'm going to a very different scenario, which is the case of ectopic OCTH syndrome, because the LINK study, as I showed you, were performed in patients with Cushing's disease. So I'm talking about now ectopic OCTH syndrome, and I'm showing the data from a French study that we published with my friend Jacques Young some time ago in patients with ectopic OCTH. And you have here the values of individual patients. There were 33 patients. And I want to focus mainly on the left part of this patient that were naive of any treatment. And what is shown here is the value of UFC expressed in times the upper limit of normal. So you can see that this patient on the left side had huge increase in UFC. You can see here more than 200 times the upper limit of normal. Of course, these patients were in very bad condition with numerous comorbidities due to this large excess in cortisol production. And what you can see here, then at the bottom, is the lowest value of UFC obtained with osilodrostat. So you can see that in all these patients, osilodrostat decreased dramatically the UFC level, even normalize it in 82% of patients. And what you have here, the number that you have here on the close to these bars, are the time it took in weeks to obtain the lowest, the nadir values of UAC. And you can see there are red circles on patients who were able to decrease their UFC level in only very rapid time, 1 or 2 weeks. And you can see that all these patients received at start, these are the number above these lines, high dosage of osilodrostat. So very differently from what is recommended by the company for Cushing's disease, that is to start by 2 milligrams twice a day. This patient receive at least 10 milligrams and even sometimes 20, 40, 60 milligrams per day. So this very aggressive drug dosage at start was able to induce this rapid decrease in cortisol level in this patient with such a high such an intense hyperactivism. So clearly, what was performed in this patient was a block and replace strategy, very different from the titration strategy, in which the idea is to put your cortisol level to 0 or to the lowest level value, and then to add a glucocorticoid replacement like hydrocortisone. I recommend to you a paper that we wrote with my French colleague, a French expert, about the block and replace strategy. It's an open access. You can download it. And we give some receipt for the use of this block and replace regimen. For the sake of time, I will go to this slide, which also a slide, a retrospective slide performed in France in 103 patients with various non-pituitary Cushing syndrome, ectopic OCTH excretion, adrenal carcinoma, adrenalatoma, and bilateral renal disease. And you have here the value of any cortisol measurement performed. So that could be UFC, of course, but also in some patients, especially for those that were treated with a block and replace strategy, with only morning serum cortisol. And you can see here that we observe a decrease of this value in almost in the majority of patients, and even we are able to control any cortisol measure in almost 70% of patients, and in almost 60% of these, we are able to control UFC. So a study showing that the drug is also active in other etiologies in Cushing disease in real life study and not in trials. This is a slide, small study, the first one to be published. We performed a very preliminary study in 7 patients treated with secreting adrenal carcinoma. 7 cases, you can see that 5 of 7 patients had a severe hypercortisolism. And you can see here the fall in UFC, the fall in systolic blood pressure, and improvement in hypokalemia. So we were able to control hypercortisolism in this 7 patients. Although we observed 3 cases of adrenal insufficiency. This is again the same side effect, especially when this patient, very fragile patients that also received chemotherapy and had a septic episode. This is a very recently published multi-center study, retrospective study of 21 patients with adrenal Cushing syndrome, meaning both benign and adrenal carcinoma. And you can see again here the results of UFC in individual patients. And in terms of response, only 33 were non-responder, 29 had a complete response, I mean normalization of UFC, and 38 had a partial response, meaning a decrease in UFC of more than 50%. To be honest with you, when I read this paper, I found that the dosage of osilodrostat was not that important, and I'm pretty sure that if the investigator had given more dosage, increased dosage of osilodrostat, they could have controlled this, because this is my experience in my department. And I will end with this slide. So I did not update for April 26 slide, but this is what we have done in January 2026. At that time, we had treated 84 patients. You can see on the camembert that 21 of patients had Cushing's disease, 12 had secreting adrenal carcinoma. We had 13 cases of ectopic CTH secretion. And using various criteria, you see here that we were able to control hyperalcoholism in 83% of these patients. But also, you can note that we used the block and replace strategy in the majority of patients, and this is because the ectopic and the secreting SAC that represent nearly half of the patient had severe hyperalcoholism. And so we had good results in terms of control in real life, because now we are used to this drug and we do not hesitate to give a higher dosage when hyperalcoholism is severe. And in terms of side effects, we had 29% of side effects, including hypokalemia, adrenal insufficiency, rare case of hyperandrogenia, but we had to interrupt the drug treatment due to side effects in only 2 cases. That is 4% of our series. So with this, I go to my conclusion, is that olzarsen allows the control of hyperalcoholism and clinical improvement with a reduced number of pills in a majority of patients with various etiology of Cushing's syndrome. I think it is very important. It's a potent drug, very potent drug, to carefully teach your patient and also screen for adrenal insufficiency, even in the mid to long term. As I mentioned with regard to hyperandrogenia and also some observations that I did not mention, but the possibility also of adrenal tumor shrinkage, and also adrenal shrinkage in patients with Cushing's disease. So also the rare possibility of prolonged adrenal insufficiency after withdrawal the treatment. I think all these are signs that we have more to learn about the mode of action of the drug. And also, I think, as I showed you, is that there's a need to reconsider the dosage and also the titration strategy according to individual case, both cases with mild disease requiring less drug and also very severe cases requiring an aggressive dosage of the drug. And with this, I thank you now for your attention.
Thank you, Professor Antoine, for your great lecture as usual. I have a couple of questions in the chat box, if we may ask them. One of the attendees is asking, what is the effect of osilodrostate on the mass size in case of Cushing disease?
Yes, there are a few observations published to date that, of course, when you have Cushing disease due to the sustained excessive increase in the CTH, you have usually hyperplastic gland. It may not be visible on CT, but sometimes in patient, if you perform CT, abdominal CT in a patient with Cushing disease, you may see hyperplastic gland. And so with this drug, there are a number of observations. We also saw it, and also in patients with ectopic CTH syndrome, that we see usually during mid to long-term treatment in a shrinkage of the tumor. This is of the adrenal gland. It's not the tumor, sorry, of the hyperplastic gland. This is very counterintuitive because our CTH is high, even higher than it was before the intake of the drug. And despite the higher CTH, adrenal size shrink. So this is also another sign that there are probably additional effects of the drug on the adrenal gland. Is it cytotoxicity? I don't know. We don't know the mechanism for this, but this is something that is observed, and we need more studies on this phenomenon.
Okay, so in case you notice there is size in case of ACTH producing adenoma has bigger in size or grown in size, do you prefer to follow it radiologically, or it is an anticipated phenomena after the use?
Sorry, I didn't catch your point.
In case if it is ACTH producing adenoma and after the use you notice hyperplasia or change in the size, how would you prefer to follow up for those cases?
So to be honest with you, well, I would say that first, this shrinkage is not associated to date. There are not that many cases published, so we have to be very careful about assumptions. But at least in my experience, it's not necessarily associated with adrenal insufficiency. So The shrinkage is not always associated with adrenal insufficiency, so it doesn't mean that you have to decrease the drug dosage. And to be also honest with you, in patients with Cushing's disease or ectopic CTH syndrome that I treat with lorundrostat, I do not follow with CT scan the adrenal glands. So I don't know today if it's a signal that we have to follow, because of course it's not mandatory to do CT scan of the abdomen in a patient with Cushing's disease. So I don't know. But to date, I don't use it as a marker of anything. CT doesn't seem to be associated with adverse effect or adrenal insufficiency. But we have to learn more about that to give recommendation.
Sure. Another question is, doctor is thanking you for the elegant lecture, and could we titrate down doses if the patient comes under the control of the disease?
Yes, absolutely. Very important question. Thank you for this one. Yeah. So if you're using a titration strategy, if your patient is well controlled for weeks or months, I think you can try, since there is this increased potency of the drug with time, I think it can be safe to try to decrease, of course, very progressively, the drug dosage, and to make sure that the disease is still controlled. I think you can do it, and it has been done in the follow-up of the LINK-3 and LINK-4 study. And even if you use a block and replace strategy, and this is what we suggest in the paper, the French recommendation paper, even if you use a high dosage of the drug, if you need to give 20, 30, or 40 milligrams per day to put your cortisol level to zero, we also suggest after several weeks of treatment to decrease the drug by 1/4, and to observe if it works. Because in several, I would say not many, because there are not hundreds of patients, but in a significant number of cases of patients who required at start a high dosage, after several weeks or months, we were able to decrease the drug dosage and sometimes to bring it to very low levels, 4 or 5 milligrams, and it could be enough to control a very intense hypercortisolism. So we recommend, yes, to try to down titrate after several weeks of treatment.
Perfect. Professor, do you recommend the objectively monitor the level of control? For how long we have to monitor before we decide to taper down the dose by measuring of 24-hour urine cortisol for like one specimen, two specimen? On what ground we think this is the time we can taper down the dose?
I think, I don't know. In the block and replace, I think we suggested to do it after 4 weeks. After 4 weeks of control. To be honest with you, this recommendation is drawn from what we observe in the block and replace strategy. I don't have any data about a patient treated with a titration strategy. It may not be the same. So this recommendation is mainly for patients treated with a block and replace strategy.
Okay. Another question is from Dr. Usman. He's asking, when would you expect hypocortisolism to occur after starting the osilodrostate? Is there any expectant timeline on average or mean study database?
No, it's very, there is a huge difference in individual sensitivity to the drug. What the company says, based on the LINK study, is that most of these events occur in the titration phase. But you have to consider that, especially in the LINK-3 study, the titration phase was rather aggressive and rapid. So it may explain this. But I think, anyone would, of course, be very vigilant or about adrenal insufficiency occurrence in this phase. I think it's much more important to remember that it can occur in the long term. Even if there is no infection, even if there is no trauma, your patient seems to be equilibrated for months, and then adrenal insufficiency can occur progressively. So this is more difficult to diagnose. So you have to educate your patient. If they complain of secondary occurrence of fatigue and so on, check ATM serum cortisol. But there is no rule, a very variable sensitivity among individuals to this drug.
Okay. And there is another question. If osilodostate can cause increase in the size of pituitary adenoma, what's your experience and observation?
Okay. Very good question. Very good question also. So if we rely to the link study where it was considered, this point was analyzed, you have to know that most of Cushing disease patients were already operated and so had usually small remnant of microadenoma in the pituitary. So it's quite difficult to analyze in most patients the pituitary MRI because there are small images with the surgeon has gone there, so it's very difficult. But what they saw what was called a significant increase because it was double-blind analysis. So significant increase in around 20% of patients, but it was usually minor increase. And there was an equivalent percentage of decrease in patients treated with osilodostat. So to date, there have been only a few case reports of significant, I would say, clinically relevant increase in size, what we call true corticotroph tumor progression that can lead to Nelson. There was only been a handful of cases published to date. So I think it can occur like it can occur with other drug like metyrapone or ketoconazole, but I think it's quite a rare event. Nevertheless, I think that it's important to still consider MRI follow-up, pituitary MRI follow-up. So it's recommended to do a pituitary MRI 6 months after the introduction of the treatment. And according to what you see, to repeat it from time to time at various intervals, depending on the patient. Of course, if your patient has nothing in the pituitary sella when you introduce the treatment, you might not follow it as the patient compared to a patient with a big remnant. But still, it's recommended by the company, and I think it's a safe attitude to do a perform pituitary MRI 6 months after the introduction of the treatment, and then you repeat it after 1 year or 2 years, 3 years, depending on what you see. But it's a rare event, I think.
Okay, great. Another question, Professor, that how important to use a cortisol assay that do not interfere with 11-deoxycortisol while monitoring? What's your experience regarding this?
This is a very important question, and I thank you for this one, because of course the idea behind this question is that since there is a blockade of the last step of cortisol synthesis, the immediate precursor, 11-deoxycortisol, will increase dramatically. You also have to consider that the observation that I made for androgen is also true for 11-deoxycortisol. I mean that it rises usually initially, but it may then decrease in the long term to treatment. So this issue of 11-deoxycortisol interference with cortisol assay may be very important, at least during the early phase of the treatment, and maybe less important on the mid to long-term treatment because of this secondary decrease. So what you have to know is that the cross-reactivity is very different also depending on the assays. And there are some assays have very little cross-reactivity with 11-deoxycortisol. Of course, the best is mass spec, but it's a number of labs do not have mass spec available. But there are very good immunoassays that do not interfere with 11-deoxycortisol. So I think the important point is to discuss with your biochemist to know which assay is using and maybe to change of assay if he has one that interferes a lot with 11-deoxycortisol.
Perfect. And another question, Doctor, if you consider that in case of minimal autonomous cortisol secretion, this is a frequent occurrence in the case of incidental adenomas, do you see any role in future that a minimal dose requirement of it can handle the patient who have some metabolic abnormalities and persistent MACE in the presence of bilateral adenoma, who are not probably fit for surgery and we do not know yet the answer.
Yeah.
So how would you see that for future horizon?
This is also a very good point. And as you mentioned, especially, Dr. Rashid, especially in bilateral tumors, because when it's unilateral, you can remove it surgically. Yeah, so I think it's a good point. Some drugs like ocilizumab could be used, but to date, we are clearly lacking of studies on this point. We have some observation, case report, and so on in Congress, but yeah. I think there is room for that, but clearly, I think we need more study to know how efficient is the drug, what dosage to use, how to monitor. It may be, in my opinion, maybe more complex to monitor than an obvious overt Cushing syndrome. But still, yeah, more study to be done.
Thank you, Professor Antoine. I think we do not have further question, but definitely this is a very evolving field, and more studies are being done, and more experience are being gathered across the globe. And it is one of the breakthrough medication in the treatment of the Cushing's disease. So yet we need a lot of questions to be answered. Thank you for your presence and a wonderful lecture. And thank you for all the wonderful audience for their active participation. And I would like to remind all the people who are attending here that this particular initiative about the EDS exchange and meet the professor, which is sponsored by courtesy of Recordati Rare Disease. And we are going to have every quarter the webinar. And this is particularly aiming towards discussion of difficult or the complicated cases. You can share even your successfully managed interesting case for the sake of sharing the knowledge. That's why we named it as an EDS exchange. And if you have certain question to be asked, we can have the different honorable guests as the professors, and they can share their ideas and thought regarding the follow-up and the management of those cases. So next webinar would be on 18th June 2026. And from our side, we invite all of you, whether you are the practicing endocrinologist, you are having a training facility, you are having some juniors under your care, and there is a link shared in the chat box, which you can submit your case for the discussion later on in the subsequent webinars. After the due consideration, you can have the chance to present, and as per the depending endocrinology or diabetes related challenging case, we will invite the expert for that scenario, and you would be speaking about that. So kindly note this link and the QR code. You can scan it and you can submit all your cases which you feel that there is some miss in the guidelines and you still do not have the answer and you want some expert input to help it management. You can also share any interesting case which you feel that it was a bit different from the usual cases in our endocrinology and diabetes field, and you would like to share that how did you manage, so we can all learn from each other. And this is the purpose, to outreach our endocrine at the level of the region and the globe, so we can share those cases for the sake of better learning journey and to help our patient, which is eventually our aim. And just to remind everyone, the evaluation form will be available 4 weeks after the webinar. Once you fill it, you again can get the link for the upcoming webinars and you can submit your cases in that. And after filling the evaluation form, you will receive on the registered email address the CME certificate. Those who missed the part of the webinar, they can again go to the EDS Institute and you can catch as the recorded session. So register and attend the next webinar as well in the June 2026. You can note down the link and you can scan the QR code. Thank you again for everyone who attends there. Thank you for all the speakers and our delegates who came here and joined us throughout the session. Have a lovely night ahead.